Hey everyone, good afternoon. My name is Ann Conrath with Avant-garde Health. Thank you so much for being here with us this afternoon for an Avant-garde Health Team Learning Collaborative webinar. We've been doing these collaborative webinars every month since May, and so we're really looking forward to the discussion this afternoon. We have a couple of representatives from Advocate Health who are going to be talking about their experience in bundled payments, primarily in CJR and BPCI Advanced. And then we'll also have our founder and CEO, Derek Haas from Avant-garde Health, and Matt Fisher, who's going to be part of our legal counsel that's going to be talking a little bit about gain share. So we have Mike Barbardi, who is Vice President of Government Programs from Advocate Health, Beth Halperin, who's Manager of Population Health at Advocate Health. And so they have, 5 years of experience in BPCI Advanced and 5 years in CJR. And then Matt Fisher is with us as well. I'm going to be talking a little bit about gain share. He is partner and attorney at Hancock, Daniel and Johnson. So really excited that you're here and excited for the conversation. Brief introductions. I've already introduced myself, Director of Sales here at Avant-garde Health, and I will toss to Porter to say hello.
Thank you, Ann. Good afternoon, everyone. Great to be here. Excited for the conversation today. My name is Porter Jones, and I'm the Chief Medical Officer at Avant-garde Health. And I'll throw it over to Derek.
Yeah. Hi, everybody. Excited to have you join us for a webinar this afternoon. I'm the CEO and founder for Avant-garde Health and based in Boston.
Excellent. And so we just want to take a moment to welcome all of our new participants who are joining the collaborative. Like I had mentioned, we've been doing this since May, and we have been really excited to facilitate the collaborative because there's been a ton of interest in how to do bundle payments and how to execute and operationalize the program within the health systems. And so I just want to say and extend a welcome to all of the new folks who are joining us. If this is your first time being a part of a collaborative webinar, we are so glad you are here. This has been excellent to share best practices in how to do bundled payments. I wanted to share that we've tried a couple of iterations on how we want to share assets with health systems. Our newest iteration is that we have all of our assets going to be shared via Dropbox. So that is a link that we will provide in our follow-up email that will include the recording of the webinar, the presentation slides. There are a ton of really incredible assets included in the Dropbox link. So please check those out. This is for the people to support y'all in preparing to do your bundle payment program as go live is looming on January 1st. Also want to do a quick shout out that we will have an October webinar as well. That'll be towards the end of the month as we secure speakers there. But the highlight of that will be gain sharing in team. There has been a ton of interest in conversations that we have had with health systems about gain sharing. We're going to talk a little bit about that this afternoon with Matt and Derek. But I think that there's a lot of interest in how to structure that. What's that going to look like within team? How do we do the distributions? What do we do with our employed versus our contracted surgeons? So we're really excited to dive into that topic, and that'll kind of be the focus for the next time that we meet together at the end of October. With that, I am really excited to turn it over to Mike and Beth to talk further about their experience in bundle payments and specifically what they have learned in doing this work and what they want to apply in team and how they're thinking about their program differently given everything that they've learned. So Beth and Mike, I'll turn it over to you.
Great. Thanks. So, hi everyone. My name is Mike Barbardi. As Ann mentioned, I'm the Vice President of Government Programs for Advocate Health. And so we'll talk a little bit today about how we structure our bundle payment arrangements here within Advocate. What's the platform we use, and then how do we take our lessons learned from previous Medicare models and apply them to team to get more and more transformational success. And so Beth will I'll be sort of the high level overview and kind of key wins and lessons learned, and Beth will dig into the details on sort of how we actually plan to attack this moving forward. Okay, can you guys see my screen? All right. So a little bit about Advocate Health. We are one of the top 5 largest non-for-profit health systems in the U.S. We've got about 18,000 physicians across our platform. We've got 13 clinically integrated networks, ACOs, or medical group divisions. We manage about 2.4 million lives in some type of either total cost of care or quality based reimbursement we got 117 value-based contracts, 72 hospitals across our footprint. So our footprint stretches from Aurora Healthcare in Wisconsin, Advocate Healthcare in Illinois, mainly Chicago-based, Atrium Health, which is throughout North Carolina, Georgia, and South Carolina, as well as Wake Forest Baptist Healthcare, which is in the Winston-Salem market. We'll go to the next slide. So just a couple key foundational beliefs around how we sort of manage care within both value-based arrangements and then in general for sort of all patients. And I think just at its core, we look to understand sort of what are the key drivers in healthcare costs and how do we concentrate our resources on the most impactful moments for patients to really deliver the right care at the right time for our patients and members. And so a couple key pillars here, and this is really how do we deliver this science to sort of all patients, and Beth will talk a little bit about it, but a lot of our portfolio is in the Medicare segment, and then we have a large portion in the commercial segment, but prevention, chronic conditions, key pieces. You can see episodes of care has its own pillar here. We firmly believe that episodes of care and bundled payments are a cornerstone of our value-based care offerings moving forward. And so not only are we participating in team, we have some direct to employer arrangements, and we have some nested bundle concepts inside of some of our full risk contracts. Okay, next slide. So we participated in BPCIA and CJR. So BPCIA, I won't read this to you, but really four main care redesign levers. And I think most are familiar with this. Really had a big push to push patients home. Unnecessary post-acute utilization was a huge opportunity across our organization. But across the footprint, we were really managing about 40,000 episodes of care, both medical and surgical, and 24 hospitals participating. And overall, we did well with about 20 million in savings, and then distributed about 12.4 million back to the organization. That was a lot higher the last couple of years of that program. We struggled with some of the pricing changes and ultimately decided to leave the program. But I think the post-acute performance networks were a big help. Sniff length of stay was a big deal, and then reducing all-cause 90-day readmissions. And I will say that we were very successful in the first three. And the last one, we barely moved the dial. And ultimately, that was our undoing in BPCIA. We could not move the dial on 90-day readmissions to the point that we needed to. And so that's one of our learnings. But we'll talk a little bit about the approach. Largely to get these savings, we really focused on sort of a care management, care navigation program that really started in the hospital and then went throughout the 90-day episode. And as we all know, team is a 30-day episode with a majority of the costs concentrated in the inpatient stay. And so fundamentally, some different levers that need to be pushed in this program compared to these two. I'm going to go to the next slide. I think just a couple of things behind the scenes. A pre-established patient relationship was hugely successful in this program. So we have a Medicare Shared Savings Program in which patients have an established primary care relationship with Advocate Healthcare. And what we saw is patients that had a primary care relationship with us had 25% fewer ED visits in that post-acute phase. They doubled the SNF network enrollment rates, and we had on average about $1,000 less spending. Patients that were just coming through our doors for surgery without a pre-established relationship, either with our surgeons or with our primary care docs, really struggled in BPCIA. I think consistent staffing and volumes, really where we had higher volumes and consistent staffing, both for care navigator and other things, were really allowed us to drive performance a little bit better. And then what we didn't do is our predictive ability to trigger episodes on the front end in the physician office or before the patient was scheduled was not very good. And we believe that in order to have sort of a shared decision-making model that is getting that diagnosis at the time that the surgery is scheduled, so you can have some conversations prior to surgery is essential to the work. And then we felt like patients that had outpatient visits within 30 days really did see a lot more savings over the course of the 90-day episode, either with their primary care physician in particular, particularly if they followed up um, on medical conditions really within 30 days. So there was some good predictive value with the number of visits that they saw their provider in that post-acute window. So just a couple opportunities for us to improve. You know, we did not have a robust physician partnership in care redesign. And so what happened ultimately towards the end of the our participation in BPCI, we had hit all the SNF utilization and the think home first work, and really reduced our post-acute utilization work to a point where we were sort of top decile in the country on some of those metrics. And we just could not move the dial on readmissions. We weren't doing anything really on the partnering with physicians on the inpatient side. And that really just led to us getting some incremental changes on the post-acute network, but not really any real transformational success. And so once all the post-acute savings was gone, we really had a very limited ability to limit our downside risk. And I think just from the structure of the way the team is designed, you'll find that post-acute success piece is going to be very small relative to what you need to achieve on the inpatient side. We had underdeveloped infrastructure for social determinants of health. That was a struggle. Again, we had limited predictive analytics for risk stratification. We found that the risk stratification in BPCIA was not sufficient enough to drive target prices, and there were other needs for patients that were not being accounted for in the target price, that when we did address those, like food insecurity or gave them meals after surgery, we saw a good reduction in readmissions. We just weren't able to scale that. And I think we needed to invest a little bit more in IT and integrated platforms and standardize more of our process tools. And so Beth's going to talk a little bit about how we're going to go about doing that. The other thing too that I think was really important that we didn't do is there's got to be some process measures, in terms of point of care tools that are visible to the clinical care team to drive change in the moment, while they're in the OR, while they're in the recovering, and then at that point of discharge, everything from movement and mobility to education and shared decision making on the next set of care. So I think all those things were key. You can see that there's a lot of opportunity for us. And I'll let Beth sort of dig in.
Okay. Oh, Mike, do you want to advance my slides or?
Oh, sure.
Oh, that's fine. All right. Yeah, thanks. I appreciate the help. Thanks, everybody. So Mike did a really good job of setting out for you, what leadership has put together for us in terms of the compass, the direction we need to go. So here at Advocate, we kind of think of things in terms of like leadership creates the compass or says, let's go in that direction. And then we have tactical teams we put together that create the map that gets us to where, leadership wants us to go. The other maxim that we look at is, over here, there's an old saying from Aristotle. I remember this from my college philosophy 101 courses is that excellence is what you do every day. It's not a one-time thing. It's a habit. It's what you do. It's what you do every day that makes you excellent or not. And so as Mike pointed out, we've got 3 maxims that we go by that we try to deliver whenever we go into design on one of these processes. Is that number 1, every patient is going to receive evidence-based care to the best of our knowledge that we're able to do that. And then that evidence-based care we found creates positive outcomes. There's this concept in the literature called unwarranted clinical variation, and that's a concept that we kind of embraced over here. And unwarranted clinical variation means it's variation that's not driven by necessarily the needs of the patient, but it's driven by the way we deliver care. And so what we try really hard is to keep that maxim in mind and create care processes that keep the patient in mind and don't necessarily flex based on where the care is given. And then the last position is that positive outcomes create value for patients, providers, and organizations. So when you do that, you have like a win-win-win strategy. The other thing that we've learned, in working on projects like this or programs like this is when you go into like a bundled episode of care kind of design, you're not really, it's kind of an error to think about it as a project. If by project you mean something that you work on for one time, you build it and you walk away and it's done and you don't have to look at it again. This work is not like that at all. You need the data systems that allow you to continuously monitor whether or not you're achieving those that maximum that every patient is going to get evidence-based care. So we always think of these things as programs, as something that you're building for the future that's going to go on in the future, and it's not build it and walk away. Next slide, please. So how do we start? The first thing we do is we look at our Epic tools, and this is where we really collaborate with our EMR people. As Mike has pointed out, this is a big place. We serve a lot of patients, and so without really sophisticated communications and EMR structures, it would be impossible to get everybody on the same page in the way that delivers values for patients. So the first thing we do is an inventory of our Epic tools. Number one, do we have a good way to identify these patients? If you can't find these patients in the large numbers of patients that come to your door seeking these procedures or these surgical episodes, you're really behind the eight ball, and so is the patient. And then we assess all of those existing Epic tools to help streamline clinical workflows. Do we have good risk tools? Do we have standard order sets? Do we have standard alerts that helps guide the clinician work, smarter notes, checklists, et cetera, things like that. And then we do a gap analysis. So this is what we've got. What do we need that we don't have yet that we need to build? So that's a big part of our pre-planning assessment. And then care coordination, what are the tools that we're using for care coordination? One of the things that's come up that we think is going to be really valuable to us is the Epic Structure Compass Rose for the SDOH and cross-functional team coordination. Next slide, please. There are three pillars that we keep in mind whenever we go into design, and this is how we believe we'll drive success in team. Number one is you need to produce high quality outcomes. Patients that have a surgical procedure and have a lot of complications as a result of that surgical procedure, it's not going to be good for anybody. It's not good for the patient. It's not good for your clinical outcomes, and it's certainly not good for the financial health of your organization. The second pillar is to create operational excellence and efficiency. And the last is monitoring financial performance and cost management. So going back to the first pillar, I just want to draw your attention to the high-performing clinical teams. One of the points that Mike made in his presentation is when you've got really good clinical teams and practitioners, you really want to support them. When you go to design a new process that you want them to participate in, it's really important to have them at the table and design on that. That's how you keep your high-performing clinical teams working and satisfied with your organization. Then the next thing is create a positive patient experience. That is going to be really helpful down the line in maximizing your reconciliation payments. So keeping all of these things in mind as you think about your outcomes are really important. And that's where the SDOH assessment comes into play. We currently have a project that I'm privileged to participate in, where we're assessing the patient at the time of scheduling for surgery for any barriers that might prohibit them from going home. We started that in April. We're a few months into that, but so far our data are very favorable in terms of like our use of SNF and IRF facilities, in that we're about 25% decrease where we are for the same time last year. We're getting really good feedback from our patients, from our physicians. Patients like it, because the scheduler asks them about their home situation. The care managers get that data downstream, and then a care manager calls the patients and says, here, we've heard that you might have problems, that your husband has to work during the day and you might not have anybody at home with you. What can we do to find out, just so that we can get that in place before you even have your surgery? But we're getting good feedback on that, and our data are very favorable. It's early days, but we're really encouraged by that. Then in the second pillar, again, excellence. You can't do excellent care if you can't identify the patient. So we plan to spend an awful lot of time on that Epic trigger tool, and then integrating our data platforms on the clinical, financial, and claims track to try to understand like what our performance is like. And then the fourth big pillar is optimizing and standardizing clinical work. We're a big believer in getting our clinical experts together to look at our standard Epic order sets and develop order sets that provide the best scientific evidence for the care of a particular surgery type that we know to be true. So we're really invested in that. And then when you engage your providers in developing those order sets and in working on these clinical pathways, that's where you really get buy-in. When they feel when it's been our experience that when our specialists and our physicians actually participate in designing these structures and these processes, we get better outcomes and we get better engagement from them, and investment in the health of the process. And then last but not least, one of the things we're really going to attempt is close to real-time monitoring, episode cost monitoring as we can. We've got, like Mike talked about, that post-acute care optimization, the home first to the homeward bound strategy. We're going to lean in heavily on that. And then to maximize reconciliation payments, we're planning to pay attention for our composite quality scores. Next slide. This is, I put this in, this is a really busy slide and I apologize for that, but, I wanted to kind of show, when we start to put pen to paper and we try to operationalize the concepts that I just described and that Mike described from a strategic perspective, we take an episode of care and we divide it into its segments. And then we look at what is the key deliverable for that segment of care and who are the team members that participate at that segment of care. And we specifically line them out and then we recruit them to help design the process and the order sets. And so as you can see in phase one, there's two phases there. There's a pre-op surgical visit. That's what happens in the surgeon's office. And then the pre-optimization phase, which we consider very important. If you don't know what kind of challenges your patient has, either medically or from an SDOH perspective, it's hard to know how to intervene early so that they're not part of barriers that the patient faces as a result of their surgery. And then you can see here, I don't want to, read the slide to you, but you can see that, what we do is we've developed key deliverables for each phase of care in each of these subsections, and then we had set teams together to actually work on creating those structures. And frequently they'll tell us that they need something that we don't already have. So for example, the example is that survey, that pre-scheduling survey that I talked about. Our care management team gave us feedback like, well, we get surprised. The patient's in, they've had their operation, and then we find out that, this lady's got to go to a nursing home because her husband works 8 hours a day. So what are we going to do about that? We find out too late. So when you include these people in the design of the process, you find out things you didn't know. During the operation phase, there are things like, for spinal fusions, there are things like standardizing implants, getting your surgeons together to standardize your implants and instrumentation, the neuromonitoring, any biologics they're going to be using. That's extremely powerful, especially in managing your costs and creating efficiencies in a more predictable operative phase. And then in the post-discharge, the post-discharge phase where the deliverable, what we're hoping to achieve is that the patient recovers at home without a surgical complication, and then we have the discharge recovery team. And again, that consists of the surgeon who sees the patient for that final post-op visit and signs off and says, you're good to go, you're healed up, and, and let me know if you've got any more problems in the future, but we're good here. The PCP is a big part of that, care management, home health, and then the data we're planning to track is a 30-day recovery tracking, SNP utilization, ED visits, readmissions, episode 30-day summaries. In phase 3, one of the things I wanted to point out is, like Mike alluded to, is we're going to attempt to do more real-time data tracking so we can identify outlier patients. What I mean by outlier patient is a patient who's had their surgery and they're just not recovering. You know, we've studied a lot of patients, and we know that when a surgery has a good outcome, the recovery period in-house is about this many days or this many days. And if a patient isn't meeting those marks, that's a patient that we need to get in touch with and pay some special attention to, so that they're not hanging around too long. Nobody wants to be in the hospital longer than you have to. You know, are they having troubles recovering? Is it an SDOH issue? But we're going to try to track that data so we can find outliers and close to real time, so we have an opportunity to intervene. And then last but not least, last slide. You know, as Mike pointed out, you know, we believe that team and other episodes of care and bundled payments models are going to be part of the future for us in healthcare. And so we're working on building the programmatic infrastructure and methods to respond as they come online. Thank you for the opportunity to be here. And I hope I didn't talk too fast. I've been told I have motor mouth sometime, but I appreciate your attention. Thank you.
Awesome. Thank you so much, Beth and Mike. And for folks, I forgot to mention this at the top, we're going to go through a Q&A portion with Beth and Mike about their experience and kind of what they're thinking about and what they want to do differently in team. So as questions come to mind, please enter them in the chat. I'm going to be monitoring that as we go along. So I want to go ahead and start with the first question. Mike, when we had originally talked about you sharing your experience here, I know that right out the gate, you said that surgeon engagement was something that you want to do differently this time around. Would love for you to share a bit more there about what kind of more specifics about what didn't go well and really what are the challenges there? And then what are some kind of specific strategies that you're going to be more intentional this time around, especially these next couple of months, but while y'all are preparing for go live?
Yeah, I mean, I think the biggest thing for us was, having to, we pumped a lot of infrastructure into BPCIA and CJR, and I think the difference between the two, CJR was a physician-driven service line approach to joint replacement for all patients, whereas BPCIA was kind of we didn't have specialists, like specialist care management folks. They were sort of, if you were working on BPCIA, you were a generalist and you were not working with specific patient populations. And so they were regionalized by hospital site. So they had each of the care managements and patient navigators were not designated by, like sepsis or orthopedics or whatever else. And I think what we found is that as you start to dig into like Beth mentioned, the evidence-based care pathways, when you've got someone who's, handling a caseload of people with sepsis and heart failure, and then also handling surgical episodes, they're just not as good as they could be. And specializing, that those nursing-led resources for care navigation is a key piece we're focusing on moving forward. And having a little bit tighter and having those folks directed by the physicians, I think, in terms of what they want to see, how they want their patients handled, what clinical touch points that they think where the patient is most vulnerable is essential. And we didn't do that the first time around, and that was ultimately why we exited the program. And did that after, we lost, a couple million, 2 years in a row. And so I think, we don't want to repeat that same mistake. And I think, Beth's team driving evidence-based practices through the physicians first and then down to our navigation team is really important.
So are you choosing physician leaders like within each service line? Or are you looking at this like at the facility level? I'm curious if you have like a
I'm gonna
bundle
let Beth,
like
I'm gonna let Beth
committee.
take that one in terms of how we construct the clinical teams and stuff.
Yeah, I would love to hear, Beth.
Yeah, sorry about that. Yeah, we're service line oriented here. So what we're doing is we're reaching out to our service line leaders, and we're actually asking them which other surgeons they would like to bring on to be part of that advisory group. So for example, we've got like an orthopedic surgery advisory group, with strong support from our service line leaders. We've got one for CV, for large bowel. So we're really fortunate in that, the surgical leaders that we reached out to have been very forthcoming. The second part of that, is once the evidence is established by these, these clinical specialists, is one of the things we do is when we publish it to the medical staff, we get endorsement from the medical staff presidents and our medical staff leadership, so that everybody's kind of speaking with one voice, and then what happens is when you get into that business, you got to, like relook at your evidence annually. So that group stays together. It's not a one and done. They stay together, as part of the program and as part of like the annual evidence review to see if anything needs to be tweaked. So we've had success with that, and so to Mike's point, that's what we're going to be doing with our team stuff.
That's awesome. So in addition to physician engagement and talking with a lot of health systems, like the to-do list is long ahead of January 1st. And so would love to hear from you both as folks think about what initiatives they want to prioritize ahead of January 1st. What, in your opinion, was like the single most impactful change that showed results in terms of reducing cost within your bundled payment patients?
Do you want to take that one, Mike?
I mean, so I think for us, again, like the best predictor of cost, whether or not we had a previous relationship with the patient and whether or not our specialist was synced up with their PCP. And so like that was a big thing. If they had a prior established care relationship with our PCP and there was a warm handoff between those two groups, obviously that's a measure for team here. And also if you're tracking on some of the other models from CMS, they are focusing on that specialist PCP interaction. And so as Beth mentioned, you saw like PCPs are a key part of how we're managing this. And I think it's really about not part of it is about optimizing patients prior to surgery, making sure that their diabetes is under control, making sure that, hypertension is under control, all that sort of stuff. Obviously, that's a piece of it. But if we can optimize those folks through PCP management, that's a big piece. But I think, where we had engaged clinicians is the biggest predictor of value. So for instance, there's a lot of motion around heart failure when we were in BPCIA. And we really only had one hospital site that was really active, where the physician champions were really active within heart failure. A lot of other groups were kind of just along for the ride. And so we did have one site that was able to, reduce their 90-day readmission rates for heart failure by 70%, through some very specific follow-up protocols. The other groups, that didn't have, again, engaged physician leaders directing that evidence-based care pathway, we laid that playbook out for these folks. And you can do all the playbook layout that you want. You can have all the task lists that you want and checklists that you want. But if people aren't using it, you don't have a engaged peer-to-peer, it doesn't take.
Yeah.
And in models like this, you need 70, 80, 90% of the time, people need to be hitting all the metrics, because that 20, 30% where you're taking losses can typically, decrease any savings that you might be generating on the rest of the population.
Right.
And we saw that over a 5-year period. So
Yeah. Beth.
Yeah, just to tag on to Mike's comments, I completely agree with what he's saying about, about how important the PCP is. The other thing is, if somebody was asking me, what's the one thing you should start doing, where team is concerned, I would standardize my order sets. That's one thing you can do that it's like a twofer. Number one, you get your docs engaged in that. When they get together and they start to discuss the evidence and how they like to deliver care. I think that we've had really good luck with that. We had a project last year where we were looking at decreasing our surgical site infection rates in bowel surgeries, and just the act of standardizing our order sets and then tracking that and providing feedback to surgeons on, here are the outcomes, from surgeons who use the order set and these standard methods, for the clean close, and here's the outcomes for the physicians who did not. When we circulated that data back for them, we saw migration into the use of the order sets, and our SSI rate went down. So things like that, where to Mike's point about how important it is to get your specialists involved, that's one good way to do that. You standardize care and you get them involved in making decisions for the organization about what is good care for spinal fusion, what is good care, for a bowel surgery. So that's one really strong thing you can do to get started.
Mm. And how long did that take you to implement? Like from the time that you started the initiative to the time when it was like in Epic and it was in there and people had access to it?
I think like the order set construction, we were really, I'm going to use bowel as an example. We were really lucky because we had a couple of sites that had already, like their specialists, they had board certified trained surgeons who had already developed some really good order sets. So we were able to leverage those and then push those out across the organization. So that only took a couple of months, so we just needed to get buy-in. So that goes back to like doing your original inventory. Do you have a group of surgeons out there that are doing spines that have really good outcomes and they've got really good order sets, and you bring those forward and leverage those across your organization. So it kind of depends if you're starting from scratch or if you've got the benefit of a group of surgeons that are already doing this, and leveraging that, and then they consult with their peers and then you get it done. But the big part of that is to track the order set use and then compare that to your clinical outcomes and then plow that data back to your surgeons for their awareness. That's a real important thing to do.
Okay, super helpful. We have a lot of questions in the chat. A couple of questions related to HCC documentation. So this has definitely been another hot topic in bundled payments. A lot of questions on how do we do this? How do we do this well? So one of the question is is your pre-op surgical visit where you capture all HCCs critical for risk adjustment?
It is important. I don't like it's important. It's not critical. I mean, in my opinion, the risk adjustment within team is not specific enough. To It's not specific enough, and so there are some faults. So you do need to be good on the HCC capture. I would encourage folks for your EMR. Most EMR companies, at least like the top 35, have some type of module related to HCC research. I'd be pushing your EMR vendors to turn that on for you. Typically, it's a standard offering, not typically utilized in specialist offices because was built for primary care physicians, etc. Or if you're not heavy into population health, you probably don't have this turned on. But I would push them. Typically, it's a free add-on. There's probably workflows already existing. I know. At least I know Avant-garde has an offering around this to help you capture those. You do have some time to resubmit claims during the episode. So you can also do it like post. You can resubmit the claims to CMS. If you do identify gaps after the fact, you can also, audit your billing. There typically is a bunch of opportunities to do that. Both with this group or with your EMR vendor. But yeah.
Okay, that's really helpful. Because yeah, there has been a lot of focus on HCCs, and I think that perspective is helpful, Mike, of like how much does it actually matter? Yeah, okay, super helpful. And then I wanted to go also kind of along that same lines of Epic with the point of care tools that y'all had outlined, because there's another question of like within our EMR, is this something that we can try and implement within the tools that we have within our EMR, or what third party, if any, do we need when we think about like point of care tools? Yeah, I would love to hear more there.
I mean, we're building a lot of stuff ourselves with our clinicians. There is not an out of the box solution. I mean, what I would say is like if you're looking to tackle both the cost to deliver care, which is sort of, within your EMR, is going to impact your, supply chain and variable direct costs at your hospital sites. If you're looking to do that and looking to reduce medical expenditures, you probably need either a third party, at least for data analytics and ingestion, or you're probably going to have to build something. And so it just depends on where you're at in your journey. And, like for instance, Epic and Cerner both have a solution out of the box, but it it's not going to touch all pieces of this, right? Like they're not going to touch the cost to deliver care, in terms of what's your variable direct cost, what's your supply chain cost. They don't touch that. They're looking specifically at the claims expenditures. And again, in order to improve your margin on bundles, you need to tackle both. And I haven't seen too many solutions, right, outside of what I've seen from Avant-garde is that tackle both.
Mm-hmm. And then my final question here for the team that we've received is related to case management. So Mike and Beth, you've touched on this, that the case management was definitely a foundation of your success in the program. And then I think this is like same for a lot of health systems that have an existing MSSP ACO. With your existing case management resources, are you planning to fold in the team patients with your existing case management resources, or are you investing in additional case management resources for team? And Advocate has about 6 hospitals in the program, just for context.
Yeah, I can take the first part of that. We're not, so previously we had invested about $2 million a year in care management infrastructure resources for BPCIA. And then when we exited the program, we moved those resources to other roles, and then eliminated some positions. Probably about 30% of those positions were eliminated. So right now, we're only running about 1,100 episodes a year on an annual basis. So right now, for teams specifically, we're not adding additional resources using within the workflows that we have today. As Beth mentioned, though, we are looking to do this for all patients. We find it's more valuable. We have some national service lines that are looking to do that. We also have some direct to employer arrangements. For that, we will be redirecting existing resources to be focused full-time on bundled payments. And so, we're going to test that out in 26, and then we may hire down the road. But specifically for team and the volume that we have in team, we're not adding care management resources. We may add other resources, like, but that's TBD at this point.
Got it. That's super helpful. Thank you. Well, Beth and Mike, thank you so much for all of the information that you shared. I know, just helpful to know what didn't go well and what you're going to do differently this time around. With that, I will turn it over to Derek and Matt to talk further about gain share and how that's going to look a little bit differently in team. So Derek and Matt, I will toss to you.
Thanks, Ann, and thanks so much, Mike and Beth. Really enjoyed the presentation. And so now Matt and I excited to talk about gain sharing, or as I like to call it, the show me the money segment, the conversation here today. So Matt is a partner at Hancock Daniel, which is a full service healthcare focused law firm. And Matt works with clients to structure business arrangements within the requirements of applicable healthcare regulations, including varying forms of value-based payment arrangements. And so with gain sharing, let me just start off by acknowledging that I recognize this is a topic that many people have strong beliefs, either should totally do this or should never do this. I would say our general view is that it is good to align people's incentives, and like where you're asking people to do work that they would not otherwise be compensated for. And like when you're trying to motivate people to meaningfully improve their performance, aligning their incentives is generally a helpful way to do this. For folks who are interested, we wrote an article around this theme in Harvard Business Review last fall with a professor at Harvard Business School, Susanna Galani. Happy to share this article afterwards as well, along with the presentation from today, for people who are interested in learning more as well. And so now Matt and I are going to just go through a series of different questions and topics related to gain sharing, both from like a legal and from a business perspective. If people have additional questions, please feel free to chat those in. We'll cover those at the end as well. So the first question here for Matt is gain sharing allowed in the context of the team program for both private and employed physicians?
Yeah, so Derek, kind of just to, as you said, help set the table a little bit for the gain sharing conversation. It's, you're definitely right that it is something that can be contemplated, and there's, if people are familiar with it, there's certainly a lot of regulatory back and forth around how to appropriately structure a gain sharing arrangement, and being able to focus within the team model. CMS has come up with certain specific rules that are applicable just for this model, for participation within the team model on top of the general fraud and abuse concerns that you'd have around, compliance with the anti-kickback statute. So in terms of, can you do it with, employed and private physicians, yes, is the basic answer. There's actually an entire list of potential outside parties other than just the non-employed physicians that you could do a sharing arrangement within the team model. When they're talking about the sharing arrangement within the regulations, it talks about being able to do it with any team collaborator, and team collaborator is a defined term within the program. And you can get that whole list, but for example, it's physicians, it's non-physician practitioners, it's skilled nursing facilities. So, it allows you to drive that alignment, as you alluded to, Derek, with a whole host of other parties that might touch upon it. And then within, the employed sphere, it might not even actually fall within that sharing arrangement because you would be structuring it likely within their employment agreement. So you'd be looking at it within that context as opposed to entering into a separate sharing arrangement with your employees, depending on how you're looking at it, structuring it.
Thanks, Matt. And then, so the next question is, so the team program, in terms of like the reconciliation payment from CMS, is about how much you're able to reduce the total Medicare spending, paid claims amount below the target prices set by CMS. From a gain sharing perspective, are you limited to sharing savings, reconciliation payments that are coming from CMS, or can you also include, internal within a hospital cost savings that are generated as well as part of like the gain share program?
Yeah, so as you pointed out, there's a couple different places where you're going to be looking at those savings, and within the specific team model gain sharing requirements, you can do it with the reconciliation payments. So just reconciliation payments, just internal cost savings, or both. Whichever approach you're going to take, you need to clearly decide on that up front and have that within the agreement. Though you're not going to be picking and choosing midstream, because with all these, with all this, you have to have a specific structure around what that arrangement looks like that you're setting in advance. But yeah, so I mean, as I said, you can pick one of them exclusively, or you can do both.
Okay, and if you do both, do they need to be both like on the same time frame, or could you do them at different time frames? Like, for instance, just like with the CMS reconciliation, that's gonna be like happen mid-year, like for instance 2027 for the 2026 performance year. Could you do like within a hospital savings like sooner than that, or do you need to kind of wait to do both at the same time?
Yeah, I mean, I think it depends on how you're going to be kind of how you want to time out those payments, because kind of the baseline is that within the team model, when it's talking about the sharing arrangement, one of the requirements is that the payments, if there is money available to distribute based off of meeting the goals, that it has to be distributed at least annually, but can't be done more than once per calendar year. So kind of a weird combination of terms there, because if you're saying you have to do it annually but not more than once per calendar year, you could time it out, so you're looking at a time period where you can align those internal cost savings along with the CMS reconciliation payments, or you might end up having a drag waiting for one of them. So it's you want to make sure you're hitting that requirement where you're not paying out too frequently, but you can determine when in the year that payment is going to be made.
Great, thanks. And so let's assume like a hospital is setting up a gain share program with its physicians. There's some organizations that made to say, we're going to share some money with like the department, for additional resources for that department, but maybe not share it with the physicians. And other places are going to make a choice of like actually sharing the money in some capacity with the physicians. And it's like focusing and saying that latter scenario. If a hospital is like allocating a portion of any reconciliation payment to be shared individually with physicians, what are options for like how that money could be allocated to those different physicians that are permissible? What are ways that would not be permitted?
Yeah, I mean, anytime you're talking about sharing savings or sharing payments with physicians who I hope everyone recognizes are viewed as referral sources, and that's where a lot of the fraud and abuse concern can arise under the regulations. The hallmark is you can't premise any of that on the volume or value of referrals or the other business that is being generated. So, when you're looking at sharing, the sharing arrangement for the team model, or kind of more generally just gain sharing, because remember, as I said, like you have specific requirements in the team model, but you also still have the baseline if you need to comply with the general anti-kickback statute requirements. So one method is you could do it as a percentage of overall contribution to savings. So looking at the total savings, if you have total savings generated, what portion on a percentage basis was contributed by each person. Another way you can look at it is you can assign dollar values for hitting certain metrics. So that way, because obviously when you're doing the sharing payment, you're going to be looking at meeting the quality of that quality of care criteria that you've built into the model as a whole, because that is the premise of doing the gain sharing. So it's you have to hit those thresholds, then you become eligible. So there it's kind of it's not necessarily like there's a black and white list that's included within the establishing regulations for the team model, but it's within those kind of generally accepted parameters and frameworks. So it's you're not going to want to overcompensate the one, if a physician happens to contribute 90% of the patients, you're not going to give them 90% of the payment, because if you tie it directly to the amount that they're putting into the program, that's going to draw a negative inference. Conversely, if you're looking at it as, someone contributed 50% of the savings, then it's justifiable to provide them 50%, pay them or, reward them for that 50% of what they contributed from that perspective.
All right, great. Thanks, Matt. Yeah, within Avant-garde, from a business perspective, our general recommendation is, if a place is going to do some form of gain sharing with physicians, to allocate that money to the physicians in proportion to their contribution to overall program success or reconciliation. And so just to kind of walk through some illustrative math around like how that would work, I'm just going to go and share my screen here. So we're just going to walk through a couple examples here. And so for simplicity here, like let's assume there's 3 physicians, and if you look at the aggregate, their cases over the course of the year, the hospital in total is earning $200,000 of reconciliation. The first physician's cases are contributing half of that, and the other 2 physicians are each contributing, their cases are each contributing like $50,000 towards that. And so, if you look at that on a percentage basis, as Matt was saying, it's like basically breaking out, 50, 25, 25%. And then let's just say for illustrative purposes, like the hospital is choosing to share 20% of that $200,000 payment with the physicians. So like the savings pool going to the physicians is like 40,000. Basically, the math would be, take those percentages and 50, 25, and 25, and times that by the 40,000 being allocated to the physicians, to like say, here's how much each physician would receive, as part of like their gain sharing in this example here. And again, like the exact percentage that goes to physicians here is 20% for illustrative. There's a number of different factors we can talk about later on that would indicate, relatively speaking, like what percent would be a fair amount to go to the physicians in different circumstances. So like let's look at a second example here. Just changing one number here, which is physician B, who now is actually, his cases are contributing like 60,000 in losses to the hospital. So the total savings, like where there's positive savings, 150,000, but the net savings is only 90,000. And so like of the people who are contributing, the positive savings, basically it's 2/3 physician A, 1/3 physician C. And so here, again, if you take 20% of that 90,000, like it works out to being 18,000, and then basically if you take those same percentages of 2/3 and 1/3 times the 18,000, this is like what it works out to being for each physician. So basically in first 2 examples, physicians A and B, A and C each contributed the same amount. They're the gain sharing pool though is decreased in this example because physician B, cases lost money into the hospital overall, didn't do as well as it in scenario A. So then just quickly to look at one more scenario here. So Matt, now the hospital as a whole now has lost money and owes money back to Medicare, despite tremendous efforts, physician A, who contributed $100,000 in actual contributions to the program. In this example, if it wanted to, could the hospital still do some sort of gain sharing with physician A or not?
Yeah, so this is where it would depend on how they establish that sharing arrangement, because as we talked about earlier, there you can look at a couple different sources for determining where did savings occur, and where are you deriving the potential pot of money from. So going back to what we talked about earlier, those 3 buckets are reconciliation payments only, internal cost savings only, or both. And if you're talking about the reconciliation payments, what the regulations say is, the gain share from the reconciliation payment can only come out of that reconciliation payment. So, using the scenario that you have up here, Derek, if this was structured as reconciliation payment only, then there is no reconciliation payment because, as laid out in the example, there's money owed back, which would mean even though, in the example, physician A did an amazing job and generated a ton of savings, there's nothing to participate in because there was no pool available. However, if you went with either internal cost savings only or the combined pool, you could look at that internal cost savings component and potentially be able to reward physician A for meeting the metrics on the internal cost savings component.
Right. Thanks, Matt. And then one other thing that just want to emphasize here too is in terms of like looking at the savings or loss here by physician, like it's possible just to look at that based off of the hospital's final target prices. But we think like in terms of being fair to the physicians, it makes sense to reflect the particular acuity of their patients to like risk adjust for the individual cases that each physician is seeing. And it's possible to do that basically by replicating the risk adjustment multiplier methodology that CMS is using to calculate the final target prices for each hospital in the program based off your actual patient case mix during the program. So like this is factoring in about 47 different HCCs, as well as like factors like patient's age, disability, dual eligible enrollment in Medicaid, et cetera. And so you can do this to basically calculate like patient level risk factors and aggregate those at the physician level to come up with like basically risk adjusted target prices specific to each individual. This isn't like Medicare is not, CMS isn't going to calculate that for you, but by replicating that methodology, you can come up with this approach. And so just to like walk through one last illustrative example here, like these are like 3 cases. In the first column, you basically they'll each have like the final target price, but then they each have different patient factors that then lead to basically different risk-adjusted target prices for those 3 cases. And then if you like look at the episode spending per case for those 3 cases, if you don't account for that patient risk, basically in aggregate those cases are in essence kind of breaking even. But then when you do factor in patient factors, it is leading to about a $5,000 positive contribution for those cases. And so in terms of being fair to the physicians, we do think it's valuable to be risk adjusting at the physician level when calculating their contributions to program success. So really, there's a lot more we could talk about with gain sharing. As Ann mentioned, we'll be doing that in the next webinar as well. If anybody has any quick questions, we can cover that before we wrap up.
Yeah, there is one question, Darren Demet, that was submitted about gain sharing with other insurances outside of Medicare without falling afoul of the kickback laws. So curious for your take on that topic.
So Matt, the question is it possible through the team program to do gain sharing beyond the Medicare fee-for-service patients that are in the program? Could you do it with other payer patients as well or not?
Yeah. So I think you'd be looking at the overall structure. You wouldn't want to create an appearance that you're overcompensating for the non-Medicare patients to cover potential losses on the Medicare side. It's always that balance. There's certainly the historical guidance when you're looking at OIG interpretations around AKS violations that you can't trade one for the other because that's going to be viewed as driving the improper behavior, what the OIG views as that improper behavior. So it's you always want to be very careful in how you're structuring any of those arrangements, because any type of gain share is going to draw a lot of scrutiny.
Yeah, I mean, I just add to so like for something like that, we did a lot of work on decreasing sort of supply chain costs and physician preference item costs and the cost to deliver care with our specialists. And we reinvested those dollars that we saved as an organization back into service line cost centers to help all physicians get either get home earlier or have new equipment or other things like that. So there are other ways that you can sort of reinvest those dollars as an organization, that, where you're not cutting checks to individual docs, that we found are very meaningful for our physicians. And so, in some cases, folks just want an extra operating room and, get home earlier and, see their kids for dinner. And, that is, there's ways that you can do that, through investing in technology or other tools that are in some cases more wanted by our physicians than an extra couple $1,000s.
Awesome. Thanks for those
Great
last
point,
comments.
Mike.
Thank you. Well, I know that we are at time, folks, so we will adjourn our session for this afternoon, but thank you all so much for being here, and we're excited to see you the next time.